Hello friends, this is Dr. Sameen Afzal Junejo from Afzal Eye Clinic, Hyderabad in Pakistan. Friends, today I will show you a video. A case was operated yesterday at my clinic and I had performed a triple procedure surgery on the left eye of the patient. She is a lady of 60 years old having a cataract with chronic simple glaucoma, and I decided to go for the fornix based conjunctival flap with the dissection of conjunctiva at the limbus along with 10-ounce capsule to make the sclera more clear and visible for further dissection of a triangular scleral flap. The patient was also soaked with the mitomycin C in a swab at the dissected part of the sclera for about 3 to 4 minutes, and after performing a superficial scleral cautery, and vigorous irrigation of the surface area, a triangular half thickness scleral flap was created at the upper border of the gray line. In this patient, I created a triangular flap because the 10-ounce capsule was not so thick and the patient was more than 50 years of age, and there were least chances of the granular tissue formation and blockage of the filtration bleb. That's why a triangular half thickness scleral flap was made, and after that, underneath the newly formed scleral flap, cystotome was introduced with the first prick inside the eye to form anti-clockwise round curvilinear anterior capsular axis as a first step towards a Phaco emulsification procedure. I do not use the dye inside to create a capsular axis. A A side port incision was given at about 8 o'clock position with 1.2 millimeter diamond blade. The viscoelastic solution was injected into the anterior chamber. Pupil is so small and I had to struggle a lot to save the iris from capture and to ensure the complete removal of all the lenticular fragments. A Phaco tip is introduced through the corneal incision. A central groove is created, engaged and pulled towards the center of the pupil so that the equator of the lens could be quite visible to split the nucleus into multiple fragments. Due to the small size of the pupil, I am facing a bit difficulty, but even in spite of that, I have been successful to lift the nucleus up out of the bag and applying high vacuum and linear Phaco, I succeeded to break the nucleus into tiny fragments. As you see, the nucleus is coming up, leaving the bag and comfortably under high vacuum of 550 millimeters of mercury aspiration mode and linear Phaco, the nuclear fragments are being removed one by one out of the eye. We should not go closer to the pupillary rim in order to create the pupillary capture. As you see, my dear friends and colleagues, that there is a total meiosis due to the release of the prostaglandins E2, and now the foldable acrylic one-piece IQ lens is implanted exactly into the bag, and the superior haptic is positioned into the bag. Again, cotton swab dipped with the mitomycin C was applied on the surface. Slightly before implanting the intraocular lens. And the lens repositioned through the trailing haptic. At the end of the procedure, the last step towards Phaco emulsification is to remove the trapped viscoelastic solution inside the anterior chamber, anterior to the lens and behind the lens. In the meantime, underneath the scaleral flap, a drainage source was created, just making a small window beneath the scaleral flap. And then, with the help of a straight veneer scissor, peripheral iridectomy was performed, followed by repositioning of the iris and ensure the visibility of iridectomy done at the or near the site of incision. And now the scleral flap is being closed by applying 10-0 monofilament nylon sutures. One stitch was applied at the apex of the triangle. The suture used was 10-0 monofilament nylon. Antibiotic moxifloxacin drops were applied on the surface of the cornea during the whole surgical procedure. A second suture was applied at the side of the triangular scleral flap, and ultimately the second size was also closed with a 10O monofilament nylon suture. Three bites are being applied on every suture. The first bite is clockwise, the second bite is anti-clockwise, and the third bite is again clockwise. A third suture is applied on the other side of the triangular flap. With the same 10-0 monofilament nylon suture. During the procedure of triple procedure surgery and phacoemulsification, the anterior chamber is quite well formed. During the whole surgical procedure, in the end, the conjunctiva was repositioned at the limbus, and the filtration bleb was completely covered with the conjunctiva, and a suture applied near the corneoscleral junction. In order to reduce the astigmatism, one stitch is applied at the site of incision with a deep bite to neutralize the pre-existing astigmatism with the rule. Conjunctival repositioning is being carried out. Whenever we apply a suture to approximate the conjunctival edges, we should take great care of the newly formed scalal flap just by covering it completely with the conjunctiva in order to avoid postoperative leakage and shallow anterior chamber can result into secondary angle closure glaucoma formation. Thank you very much, my dear colleagues.